be a wonderful session. I would like to introduce now Dr. Mansouri, who is an amazing glaucoma specialist. He's a consultant ophthalmologist at the Glaucoma Center, Lucerne, and an adjunct professor at the University of Colorado, Denver. He is the associate executive vice president of the World Glaucoma Association and a clinician scientist, and he has authored over 225 research papers. So glad to have you here. Thank you so much.
Good afternoon, and thank you to the Scientific Committee for the invitation to speak here, especially about one of my favorite topics. So I'm trying to meditate while I'm speaking to you, and at least to be mindful about that. SLT as a first-line treatment management in glaucoma, yes or no? Sorry, I'm trying just to advance here. These are my disclosures. Well, this is a topic I often discuss with my colleague and associate in Lausanne, Dr. Andre Mermou, who many of you in India know well. And he's more of the old school, and he's not so convinced about SLT being a useful first-line treatment, whereas I am. And, you know, our fellows that we share sometimes are torn between one side or the other. I'm going to make a few arguments, give you actually 6 reasons why I think SLT is a good first-time treatment for glaucoma patients, and even patients with ocular hypertension. Well, first of all, is going to be that it is effective and it has a good durability, and second, that it can be repeated, and then a few more arguments as you see here. Our old dogma of SLT not working very well was based on, you know, our old experience of exhausting all medication options, 1, 2, 3, even 4 molecules, combination of them, many years of trial and fail before we then would go to SLT. And of course, by then the trabecular meshwork was largely deceased, and unsurprisingly, SLT didn't work well. A large landmark study that you of course know, the LIGHT study, spearheaded by Gus Gazzard here pictured, showed that when you use SLT in patients without any previous IOP lowering medications, well, the effects were extremely positive in terms of not only quality of life, which was the primary outcome in the LIGHT study, but also in terms of IOP lowering, in terms of reduction of glaucoma progression, and in terms of reducing the percentage of trabeculectomies that had to be performed later on. I'm not going to guide you through this study because it would take more time, but needless to say, it was a very large study, initially over 700 patients included, and then in the extension publication, this publication that reported 6-year data, 524 patients followed up for that long period, more than most published mixed trials, for example, do report. And as you can see here, 70% of patients were at their target IOP without any medications. And fewer of these SLT-treated patients had any glaucoma progression compared to those who were on IOP drops. Fewer patients, almost by 1/3, required any trabeculectomy. And unsurprisingly, it was very safe. Only 1% of patients had IOP spike. And that's interesting because traditionally we used to say, well, SLT can cause IOP spikes. And more IOP spikes in patients who may have pigmentary dispersion or pseudo-exfoliative glaucoma, IOP spikes that in patients more advanced might be actually very dangerous. Well, now we know that if you do not overtreat in terms of energy, if you actually use this lowest energy levels possible that give you the occasional cavitation bubble, well, then IOP spikes are a very rare occurrence, especially if you pre-treat with IOP lowering meds, 1 drop or 2 just before you do your SLT. These results were fortunately also confirmed, you know, from a different population, different continent. This is the West Indies glaucoma laser study from the Caribbean, spearheaded by Tony Realini, who you can see here. Another large study conducted in 265 eyes of Afro-Caribbean patients. As you know, again, patients who present sometimes very bad glaucomas, patients who sometimes do not respond well to surgery. And here, bilateral single session 360-degree SLTs were performed, both eyes, for practical reasons mostly. And as you see, IOPs were reduced by about 50% over 8 years. I was blown off myself when I saw these results. I didn't know that so many SLTs could work for so long. And this is somebody, myself, who has been doing SLTs as first-line treatment for over 10 years. So when done correctly, initially, it seems to be really durable in a large percentage of patients. And look at this other finding. The medication-free survival period for the initial SLT was 85 months, about 7 years. And again, in terms of safety, well, no safety issues reported. We have some other older studies that looked at duration, and again here they did show that duration didn't have to be very short. I used to tell my patients when I propose SLT to them, well, you know, the success rate is around 50-50, so 1 out of 2 that it works in that eye or not. We wait 2 months to determine the effect, and then if it works for a year and a half, and then we need to repeat it, but we can repeat it. And I still saw that as a very positive response. Well, these studies, the newer ones and the older ones, show that, you know, I was probably underselling SLT. Another study here from MANSOURI and colleagues, where the average time to failure was even longer than 2 years, 3 years on average. I used to be told when I was still a resident that, well, it's not a good idea in pseudo-exfoliative patients, a category of glaucoma that we have a lot of in Switzerland. Almost 50% of my patients have pseudo-X. Well, not really true. If you do not mistreat, meaning you do not treat at high energy levels, you should avoid treating all 4 quadrants in one session. Well, it's safe and it is very effective, as this study shows you. Another study again showing you a 31% IUP reduction at 1 year after a single SLT treatment. Again, as you see here, it's safe and it's as effective in pseudoexfoliation as in POAG. And this is, you know, reported in a few other smaller studies. This is definitely reported or seen in our cases in Lausanne. In fact, we have a registry that so far entails 1,100 patients who had SLT, which we have not published recently of, but we only published the first 200 numbers. But I can tell you that this is something we see in our real-life SLT registry of 1,100 eyes included. This is an older study from our group where we looked at normal tension glaucoma, another pathology where supposedly SLT doesn't work. Well, wrong. It seems maybe not to work because you start at lower IUP levels, which may be around 18 or 17 as in this study, and you go down to more moderate IUP levels again at around 15. But when you look at percentage reduction, it's still another 20% or maybe more corresponding to what one prostaglandin might give you. So it can also be effective in normal tension glaucoma. Now, this was the efficacy, this was the durability, and what about the repeatability? Well, the LIGHT study looked into this question as well. The protocol was limited to performing only 3 SLTs over this period. So they do not have, by design, unfortunately, I would say, any data about if a 4th or 5th or 6th SLT might work. But they reported that the duration of the second or the repeat SLT was at least as long as the initial SLT. It might even work longer if you repeat it. And the repeat SLT itself led to a drop-free IUP control in almost 70% of patients at 8 months. Again, it is repeatable at least twice, and it works at least as well the second time than the first. And here you see the Kaplan-Meier survival curves for this repeat SLT. A very interesting study that I saw, unfortunately, only about 8 months ago. It has been out since 2014, and that is about to change, or has started already to change my treatment patterns in Lausanne, is this one. Is this study from China, based on the LIGHT study, where the question was, if the first SLT doesn't work, is it worthwhile repeating the second one or not? In the past, and based on some previous studies, my approach was, well, if my first SLT doesn't work after 2 months, no need to repeat it. It's probably not useful. Let's not waste patients' time. Let's put them on drops right away. This is what I used to do till I saw this study from the China LIGHT study. Here they found that even if the first SLT doesn't work, the second one might work. And this was done in 285 eyes, so sufficiently large study. And they found that the mean IUP after repeat SLT in these initially failed cases was 15.8, very similar to those who had a good result after the first SLT that was successful. The effect of duration was at least as good, if not higher. So in essence, it may be, at least in Chinese eyes, this needs to be replicated in non-Chinese eyes, of course, but based on this study from China LIGHT study, it may be worth it not giving up on the first SLT not working, but trying it the second time. I'm really impatient to see these results from other populations, and we are definitely going to practice or to change change our practice in Lausanne and look at our data after a non-successful initial SLT being accompanied by a second one. How often can it be repeated? The Wiggle study, again the Caribbean study from Tony Roalini, looked at up to 3 SLTs, and they found that the third SLT works well as well. This is another study, a smaller study of course, where they looked at the repeatability, and they found the success rate of the second SLT was as good as the first SLT. IUP spikes still a rather rare occurrence. And these are our data from the Lausanne registry, and we have data from some patients who had more than 3 SLTs, which we have presented and we will submit hopefully soon. And we found in only 25 eyes, so a small subset where we have currently more than 3 SLTs, that 60% of these eyes who had their third SLT had more than equal or more than 20% IUP reduction, and you can see the individual numbers in this bar chart, and no adverse events were observed. So these were my main arguments why we should use SLT as first-line treatment. I have a few smaller arguments to make here in the remaining 4 minutes. One is that SLT works not only well during the daytime, but well at nighttime. And this was shown a while ago at the sleep laboratory at UCSD in San Diego, that very few medications have a nighttime effect. Prostaglandins do, most others do not really have. Beta blockers definitely do not have, but SLT has an additional nighttime IUP lowering effect, so it gives you more uniform 24-hour IUP reduction than most of medication classes do. Another good argument to use it. IUP should be treated not during the daytime only, but at nighttime. It's a 24-hour disease. And of course, maybe the biggest argument is that we do not need the patient's acceptance of this treatment for it to work. It is adherence-free. And very few medications such as this one take the medications with them all the time as they should. Most of them forget them, do not want to use them, but do not tell you that they do not use them, of course. You have the problem in every country where you practice. Other patients may want to use them, but they have problems, physical problems, arthritis or others, to apply those drops. I'm one of those patients or subjects who is unable to put these drops easily, even my artificial tears. I need a good mirror and some time to put in a simple drop in my eye, and I'm not yet 75 years old and suffer from arthritis. So this is another problem that drops present to patients. Cost is an issue, maybe not in every country, but in more and more countries where healthcare budgets get really strained, and whatever gives patients good control, good quality of life, and low cost should, in my opinion, be prioritized. And it has been shown through different studies in different settings that SLT is more cost effective than medications, and sometimes even more than generics when they are used. And again, you do not really need to worry about the safety effect. If you perform it correctly, it is a safe treatment. IUP spikes are in reality much lower than this 10-12% when you use low energy levels. And the COAST study going on in the US is evaluating if you can use really the lowest levels of energy routinely. And at least our experience in Lausanne, using usually 0.3, 0.4 millijoule for most patients, especially those who have some pigmentation, shows that these lowest energy levels are actually enough. I would just highlight one category here that can be problematic, although very rare, which is the hyperopic shift that you can have in patients who present some corneal haze. It's very rare. It happens probably 1 out of 500, 1,000 eyes. There are very few case reports out there, but it generally occurs in women who have moderate to high myopia, and it can be problematic. Not all of them go back. So in essence, SLT as first-line treatment in glaucoma is safe, is effective, is durable. It can be repeated at least 3 times, maybe more, and should definitely be considered as a good option for patients routinely. Thank you for your attention. Hopefully I will see many of you very soon at the World Glaucoma Congress in Honolulu. Thank you.
Thank you so much. Thank you so much, Dr. Mansouri. We are very lucky to have you here, and 8 years sounds very impressive. I just want to ask one thing before I open the question. How often do you follow up the patients to monitor the glaucoma, to intraocular pressure?
Well, I see them at week 1, because although I mentioned IUP spikes are very rare, I still like to see them after 1 week. Although I would say, based on recent data showing that IUP spikes, when performed correctly, are so rare, it's probably not necessary anymore. So I may change my practice pattern here. But I see them at week 6 to 8. This is when I determine the response. We need to wait. Seeing them even at 1 month is probably not enough, simply because of the way SLT works, which we still do not very well understand, but biochemical changes taking about 6 to 8 weeks to function. And after that, the follow-up is a usual glaucoma follow-up.
Thank you so much. We open for 4 questions. So
Follow-up to your question is the number of times patients come back, the number of times they call for review, because if you look at the LIGHT study, it says 1 in 5 actually progressed after SLT. So I think it does matter where you set your target IOP, how often you see patients, because 1 in 5 progressing in 6 years is quite a large number.
Well, it's like any other treatment. You really follow up your patient based on the stage of the glaucoma, based on whether they reach their target IOP or not. But I do not see any difference in the way I plan my follow-up visits based on whether they are treated on SLT versus whether they are treated on medications.
Dr. Kong has a question that's very interesting. Everyone listen, because 2 titans facing each other is very interesting for us.
No, great presentation there, Kaweh. I'm wondering, how about patients who have had failed filtration surgery or failed mix? Failed filtration surgery patients, we tend to, traditionally not repeat SLT. But what are your thoughts on those patients? Will SLT still work in those patients?
The question is SLT in failed filtering surgery eyes. I would say I'm a low believer, but not a non-believer in doing it. There are a few case studies published that show that it may have some effect. I do not really understand how it would work. If you have if you have already done subconjunctival surgery, trap, deep sclerectomy, then peripheral stent, you already have this bypass, which is now apparently not working because of scarring happening. Usually at this stage, your trabecular meshwork is very diseased, because we traditionally kept at least filtering surgery to more advanced stages. Now, with the change that we have been doing since then peripheral became available, but we may do subconjunctival MIP surgery earlier. Maybe it happens in some patients whose trabecular meshworks are not fully diseased, and maybe SLT might work. But I would not advocate it as a routine way to go to the next stage when filtering surgery fails. I think the likelihood of it functioning is very low. Not zero though, as we see from some published case reports. I have done myself a few cases. These were patients who were just adamant they would not want any other surgery, so I had no other option, so I would offer SLT. And anecdotally, a few of them gave some effect. Placebo or not, or maybe still functioning that trabecular meshwork that was stimulated, possibly. We don't have any good study evaluating this question. It would be interesting.
MANSOURI, I think it is a very good encouraging study, and thank you very much for that. But I have a little different opinion about it. After doing around 250 cases of LCT in Indian situation, I realized that it is not working to our expectation. At that moment, I had the occasion to talk to Dr. Latina, and he said it might be a racial variation, and it works in Australian eyes, and it is working very well. I traveled to Australia, talked to the people, 3 hospitals, and the surgeons were doing it, and I found that it is working in Australian eyes. Then I inquired a little deeper, and they have repeated 5 times, 6 times, 7 times, because the insurance is paying for it. So, but anyway, our eyes didn't work to our expectation, not that it is failure in all cases. And the results are transient. After 4 to 6 months' time, I had to repeat it in some cases. And I was not that encouraged to do it. But after listening to your lecture, I think I'll start doing it again.
Thank you for your comments, and I think you're right. I mean, it still is not going to work in everybody, and some people may be over-enthusiastic by these clinical trials and may be over-promising to the patients. I still try to remain a bit more modest. I do not tell my patients that the success is 70 or 80%, as these studies find out. I try to undersell, and I have upgraded my 50% to 60% when I present it to patients, and I still tell them that on average the durability is about 2 years. But it's still something that most patients perceive as really worth it compared to medications and opt for. And then if your response happens to be higher than that, more in conformity with these large studies, well, fantastic, everybody's happy. But yes, do not oversell, maybe undersell even, because sometimes clinical trial data also do not reflect real life data. And again, these are populations as well. These are very limited populations. Caucasian in the UK Caucasian populations with their UK ethnic mixity that they have, which is different from other countries, or Caribbean. So what some clinical trials find may not apply to real life setting in different ethnicities. So it's good to remain more on the cautious side.
All right. Thank you very